The movement of palliative medicine or palliative care started in Kerala, Calicut, the south part of India, where Dr. Robert Rycross and Dr. Rajgopal, they have started this movement. These doctors, they came from London and they have given this movement to India in 80s, and from there it has started spreading a lot. That time we were not knowing the word palliative care, so basically this concept is very new. In 1994, the first time Indian Association of Palliative Care was started.
Basically, this palliative care is concept. So what we used to say, we are not going to add days to their life, but whatever the life they had, we are adding life to that. It was the 1992, the idea for formation of Indian Association of Palliative Care was born, which will include the doctors as such, as well as the nurses also and paramedical staff. And Dr. Akram Lal, he was the first secretary for the Indian Association for Palliative Care.
आ जाओ निमिषा, आ जाओ, वेलकम।
कैसे है?
बस ठीक है, सांस बोल रही है और क्या है। अच्छा। बाकी सब ठीक है। हाँ। In '94 sometime, the conference was organized in Varanasi. At the end of the conference, Dr. Pandey was elected first president. My experience is that palliative care was a part of the pain society. It was not a separate specialty till 1993.
How do you perceive the change occurring in palliative care?
Perceived change. It's a lot of changes nowadays. It was very hard to convince the authorities to recognize palliative care as a separate entity from pain. They had difficulty in recognizing pain also.
So it's our job to give
Yeah.
life to their days
Life- no.
left behind. Now we have got a project, an ICMR project. 10 centers in North India have been trained. They are labeled as cancer treatment centers, and Lien Collaborative has helped us do that in collaboration with AIMS and APHN. And now we are training 10 more district hospitals. Each center is training another 10 district hospitals to improve the network of palliative
That's
care
great.
in Northern India.
I'm really happy to know all that because I never knew that palliative care will grow so fast.
That is the vision of Professor Sushma and late Dr. Cynthia Ghosh. She was actually pivotal.
There was already some increasing awareness of palliative care development already in India by the time we developed this program. So there was a lead Indian organisation for palliative care. They were already very much part of the Asia Pacific Hospice Network. So there was already some major foundations that had occurred in India. So it was a right area to then build on what was already known and what had already been developed.
In 2012, a national program was launched in India to adopt palliative care across the country. And this initiative has been constantly challenged with the service provider awareness, opioid access availability, gaps in the healthcare system, and also budget constraint. We realize there are about 7 million or more patients in a year that need palliative care, but only 4% has access to it. So in 2016, the APHN collaborated with the All India Institute of Medical Sciences and Kasturba Medical College in Manipal to introduce the Lien Collaborative training into India.
The biggest change or milestone I can say happened in 2014 when Narcotic Drugs and Psychotropic Substance Act was amended. Everything was simplified, procuring, storing and dispensing. This was a big important change has happened. And in 2012, Medical Council of India started and they recognized palliative medicine as a dedicated specialty and they started MD palliative medicine. And then we started working for DNB palliative medicine, which is equivalent to MD palliative medicine through National Board of Examination.
If you look at historically palliative care movement in India, it started somewhere in mid-1980s. Between 2010 to 2020, the growth was very limited. Predominantly, the focus was on community palliative care. So that means that people used to work in silos outside the hospital where they expected hospitals to refer to them. The principal work through Lien Collaborative was the CTC program, which we initiated from 2016 onwards. So when the 2016 work started, what we tried to do is to bring palliative care right in the hospital where the action was happening.
What CTC did to us, it has given us a framework in which we can approach and use the step ladder pattern to do the things in the right way and not be left alone. We had such wonderful mentors in Madam Cynthia and Dr. Sushma, and especially the team of mentors, Dr. Salins, Dr. Mayank. They were always there, and I used to call them sometimes for a difficult patient. They were there to help.
We want to send this patient home. What are the things which you will definitely like to explain before sending patient home? We found that there is a deficiency, that close collaboration of mentor with the centers. So this is what we do in the CTC program, that we discuss that this particular center will be mentored by this particular faculty throughout the year. This made a huge difference. You know, faculty starts thinking that this is my center and I have to look after. And the participants from the centers, they start thinking that this is my faculty, and whenever I will be having a problem, I will look for this faculty. So this was a very successful step.
Moksha Dham is a place in Varanasi where people come to die. Sort of an ancient primitive hospice, but there is no medical help, no medical facility which is available there, no nursing facility. People believe that if they come to Varanasi in the last days of life, they are able to attain salvation. See, in our culture, palliative care is an ancient concept, but the way we implement it now is modern and it is really welcome. And it brings me and reminds me of the concept that suffering is optional and pain may or may not be inevitable.